Thank you very much. So I was here once a couple years ago, I think, and I spoke about macular degeneration. So today I was asked to talk a little bit more about vision loss in the elderly, less specific to the macula, but sort of the common reasons for which older patients may lose vision in our society today. So what I plan to do over the next 45 minutes or so is just to go through some of the relevant anatomy of the eye, so understand the different locations that we're talking about within the eye as we discuss the pathologies. And then I'm going to discuss the four sort of principal reasons that people lose vision in Canada today due to age-related visual loss, and that's cataract, retinal vascular disease, glaucoma, and the most common reason, wet macular degeneration. So as a retina specialist or retina surgeon, that's the one I treat the most, so we'll spend a little bit of time talking about macular degeneration. What I'm going to try to do, what I've been asked to do, is just sort of emphasize how we treat these conditions today, our current treatments, and a look towards some of the future treatments as well. So why are we talking about the eye? Well, because life is beautiful to look at. So this is my little girl, Jenna. And so we look at beautiful things, and we want to preserve vision so people can see their kids and grandkids. I always practice my talk in front of Jenna, and that's Devin there. And so I always put a picture of them in so that they stay interested while I'm rehearsing. So I've also asked Jenna to give us a demonstration of what it's like to live life if you're visually impaired. So my next quick video here is just Jenna, so that the people listening to Daddy's talk can understand what it's like to live life with visual impairment. So this is Jenna, that's Devin. I'm just asking her to show Daddy's patients what it's like. Daddy's when he gives this talk, what it's like to be blind. So she's going to put that on. And now she's going to show you what it's like to live life blind. So you do lots of weird things. You can still walk, you can still get around, you can still do what you need to do, but you tend to do things like walk into the wall, like here she is, bang! There she is. But,
I'm sorry, we didn't realize we had it muted. Our apologies.
Okay, so hopefully they missed the narration in the audience, but that was Jenna telling us what it's like to be visually impaired. You can walk into the walls, you can hurt yourself, there's higher risks of fall, higher risks of depression, and in fact mortality actually increases as visual acuity decreases. So we'll start then with an introduction to the eye as an optical system. So I always make the parallel that the human eye is just like a living camera. So if we want to look at something like the Ottawa Senators logo that we don't see often anymore, of course the camera focuses this into the back of the eye. So you have a lens in your camera and focuses the image, an inverted version of the image, onto the film of the camera. And the eye works roughly the same way. So the eye has a lens, just like the camera has a lens. The camera has a film, and in the human eye, that film is the retina. So the retina is the film in the human eye which develops the picture, and then the optic nerve takes that signal to the human brain. So if we think of the eye then in cross-section, we can consider the important components of the eye. The clear glass windshield of the front of the eye is the cornea, the lens which helps to focus, the pupils, the space through which the light comes. The light's focused at the back here on the retina, and the optic nerve takes it to the brain so we can interpret what we're seeing. And we can simplify it then and just talk about the really important components, and they're the cornea and the lens, which really do the focusing of the eye, the retina, like the film in the camera, and then the optic nerve that connects the eye to the brain. And in the diseases that I'll talk about, the lens, of course, is what's affected when a cataract develops. The optic nerve is affected by glaucoma, and then the retina is affected by both retinal vascular disease as well as macular degeneration. Macula, of course, is the center of the retina where all of our fine acuity comes from, and that's what macular degeneration destroys. So now we'll talk about these specific conditions. We'll start with cataract. Cataract is just the loss of clarity of the lens that occurs in every single individual in the world that's alive today. Your lens becomes progressively more cloudy as you age. At a certain point it becomes so cloudy it impacts your vision. That's when we call it a cataract. On a world scale, on a global scale, cataract remains the most common reason for visual loss. In the Western world, in Canada in particular, we treat cataract very effectively, so we have few people blind, but we still have a significant portion of the population that may suffer visual impairment due to cataract. It's the most common surgery by far performed in Canada today, is fixing a cataract. So it's a surgical procedure to repair it. This is just an image showing a nice clear lens and then the blurry lens of a cataract right here. And you can see it's harder for light to get through there, and therefore everything is nice and blurry. So we fix it with surgery. I'm going to show you the surgery. So I'll just go through the steps of cataract surgery so you can understand how it's treated. When we have an eye and we take it for cataract surgery, the first thing we do is we create a nice hole in the cornea, so we create a clear corneal incision. Then we fill up the eye with a viscoelastic substance. It's a clear, very, very viscous substance that keeps the eye formed so it doesn't collapse while we're taking out the cataract. Then we create a capsular rhexis. So we make a small hole in the bag that holds the lens. So we open up the front of the bag so we can get access to the lens. And then we fill up the bag that holds the human lens with another bit of fluid so that the bag is filled with fluid, and now the lens is separated from the bag and it's floating in there in this fluid. Then we go in and we split the lens into 4 pieces. So we split it up into 4 pieces, and then we use a special suction instrument to aspirate and remove the pieces one at a time. Then once the pieces of the lens are out of the eye, we take an artificial lens, we slip it through the clear cornea incision, we slip it through that opening in the capsular bag, and we position it in where the old human native lens used to be. We rotate it into good position, and now they have a nice artificial lens in their eye to focus the light. I'll show you from the surgeon's view so you can appreciate the video I'll show in a second. So on the surgeon's view, we first make that clear cornea incision with a sharp blade. We then fill the eye up with viscoelastic. We then perform the capsular rhexis. So we're taking that clear bag that holds the lens and we're making an incision, like a can opener incision, in the front of it so we can get access to the lens. Then we groove or split the lens into 4 pieces, and once it's separated into the 4 pieces, we remove them one at a time with a special suction instrument that uses an ultrasound to fragment and suction out the pieces one at a time. So I'll show you the video of what it's like to take a human cataract out in real life. Don't blink, because it goes fast. So here it is. So here's the human eye. So that's that first incision. So this is real time here. This is the clock in real time. This is not sped up. And so we've got the incision and the viscoelastic. We're just putting that viscoelastic in to keep the eye formed. Then we come along, do the capsular rhexis. So here we are, just grabbing the capsule and making that incision, that round incision in the capsular rhexis. Okay, so we have access to the lens. Then we use a bit of fluid to fill up the bag again. So we're going to inject some fluid so the eye, the lens nucleus, the lens itself is now freely mobile and can rotate in this lake of fluid within the bag. Then we'll split the lens in 4. So we're 30 seconds into the surgery, real time, split it into 4 pieces, okay, and then we'll insert the suction instrument to aspirate out the pieces of the lens and break them up. And you can see there's no red reflex here because that lens is very cloudy, but watch now as you suck out these pieces of the lens, watch the red reflex come back. See that? So now you have a nice clear view into the back of the eye, and that took less than a minute. And then we're going to insert the folding lens, and so a bit more viscoelastic to reform the bag, and then we'll insert the foldable lens through the same small incision now, so small you don't need any sutures, and the lens unfolds, opens up, unfolds inside the eye as we aspirate out that viscoelastic and suck out all the foreign substance. So we're just left with a nice lens unfolded in the bag. We're aspirating out all the viscoelastic there. And then as we finish that, we just have to sort of hydrate the wound, add a little fluid, just to make sure that the wound is well sealed, and it's well sealed. So that's 1 minute and 29 seconds incision to close to extract the human cataract and install a new artificial lens in real time. In case you missed it here, we'll just quickly do it again. So there's the incision. So lots of time. It only takes 90 seconds. So we fill it up with the viscoelastic. You can see you can't see any of the retina, any of the red reflex there at all through that dense cataract. We've taken off, done the capsular rhexis, opened up so we get access to the lens there, and then we'll use the a little bit of fluid there now just to get that lens freely mobile and spinning within the capsular bag, and then we'll come in and split it into 4 pieces, so it's sectioned now nicely into 4 pieces there. The patients have a very positive experience. It's only topical anesthetic. They're in and out of the operating room before they get a chance to become nervous. and then we're aspirating out the pieces. We get that nice red reflex as the lens is extracted. Some patients ask to have their lens afterwards. They wonder if they could take it home with them, their native lens, but of course it's all fragmented up into little pieces as it's sucked out. And there goes the new lens inside the eye, and it's going to unfold in a nice, beautiful position as we extract the viscoelastic, that jelly-like substance that kept the eye formed while we were doing the surgery. Aspirate that out of the eye, and it rotates into position there nicely. Med students come with us and get assigned to our room, and they watch 25 cataracts in a day, and they think our profession is so boring. But it's very rewarding afterwards, so when the patient's vision is significantly improved. So what's new in cataract surgery? Well, previously we were limited to inserting only what was called a monofocus lens. So the new lens we put in the human eye could either see things at distance or could be set to see things up close. But unlike our human lens, which can accommodate, it can't see things at multiple different distances. So nowadays we have multifocal lenses, and we have specialized lenses that are unique and tailored to the specific patient to correct all of their refractive errors so that they won't need any glasses at all after surgery. So we're evolving towards cataract surgery becoming like refractive surgery to get rid of glasses. The main step forward, though, is this ability to focus at both distance and near. This requires some very special imaging and measurements of the human eye, that specific patient's eye, in order to get absolutely the perfect correct lens inserted for each specific patient. Remember that our eye is designed actually to put objects that are far away in focus on the retina, so the length and the length of the eye correlates to the focusing power of our native lens to put distance objects in focus. The near object, when we try to focus it, our eye is not quite strong enough to focus an object at near, and so that must be focused behind the retina. If you're young, you can accommodate, increase the strength of your lens inside your own eye and see things up close. As we age, we lose that ability, so we have to put reading glasses in, so you slip a second lens in front of your eye, and now that added power can bring things into focus on the retina. But what these new lenses are, these multifocal lenses, they actually split the image here with these concentric grooves, so you can focus a distance and a near object simultaneously. So when you put those inside the eye, you can have your distance and your near objects simultaneously in focus at the back of the eye. And that's excellent if you're a younger patient. But as you age, your ability to not become confused by having two simultaneous images formed on the retina decreases, so you get some visual confusion when you use a multifocal lens. As well, the light intensity from the two objects, the distance and near objects, is split, and so things are not quite as bright as they should be, and you lose contrast sensitivity as well. And if you have other visual impairments such as macular degeneration, and you further degrade the image quality with a multifocal lens, you can really actually impair somebody's ability to focus. So these are beautiful lenses. However, there's some certain drawbacks to them with the visual confusion and the splitting of the image. As well, they are very expensive. They're not covered by OHIP. So cataract surgery currently costs our hospital about $435 a case, but these lenses can be several $1,000s each, and so that's cost that's borne by the patient. So they're not always a very good choice at all for the elderly. And in my patient population, I always tell them that the lens that's paid for by OHIP is a very good lens. It's an excellent lens, and you just have to buy a pair of drugstore reading glasses afterwards, and instead of spending several $1,000s, you can have excellent vision for just a few dollars. So that's cataract. We'll move on to glaucoma. So glaucoma is a spectrum of disorders that cause the pressure in the eye to increase and thereby damage the optic nerve. So glaucoma is all about the pressure inside the eye, the pressure increasing, and that pressure is pushed in here on the optic nerve, the delicate back of the eye. And what happens is as the pressure goes up, it compresses the nerve, it squishes the nerve. We call that cupping the nerve, and it basically hollows out the inside of the nerve, destroying the fibers that would otherwise carry the signal to the brain. And so that process takes a healthy optic nerve like this with a small cup in the middle, and as the cup size increases, as the pressure goes up, you can see there's less and less viable nerve tissue, and eventually it becomes all this one big giant cup, and the patient becomes completely blind. So it starts actually by robbing you of your peripheral vision, so your visual field starts to shrink and constrict in, and eventually you're left with just a tiny island of central vision, and then eventually that goes away as well. So treating glaucoma is all about controlling the pressure inside the eye. So we do that with a whole bunch of different drops. There's a sample of some of the different drops that patients can be using. Or we make a hole in the eye, like we see here, so that the fluid can leave the eye more easily, and we can reduce the pressure inside the eye by increasing the fluid outflow from the eye. There's a certain type of glaucoma which is actually curable, acute or angle closure glaucoma, where all of the aqueous outflow is suddenly blocked at once, and that causes the pressure in the eye to rise up to a very high value, from normal 15 up to 60 or 70 millimeters of mercury. The way that happens, again, you consider the eye here in cross-section. We'll zoom in here on the relevant anatomy. So aqueous is produced here at the ciliary body, so that's always producing some fluid, and it's dripping out into the eye, nourishing the eye, clearing the eye of contaminants. And this aqueous has to flow between the iris and the lens, so in that space through the pupil, and then comes in here to the anterior chamber angle where it meets the canal of Schlemm, and it flows out through the eye through this canal of Schlemm, out into the episcleral veins, and is pumped away. So there's a continuous circulation of fluid inside the human eye, and the pressure of the actual eye is regulated by how effective that circulation is going on. If there's too much outflow, your pressure is low, or if there's not enough production, your pressure is low. If there's too much production, or most commonly, if outflow is impeded, then the pressure in the eye will rise up. So normally there's a problem here at the canal of Schlemm, which causes the pressure inside the eye to raise up. In acute glaucoma, actually what happens though is the iris and lens touch. So you get a little touch here between the iris and the lens, and so the fluid can't get through there. So none of the fluid makes it into the front of the eye. So the fluid ends up building up here at the back of the eye, and that causes the iris to bow forward. So the iris gets pushed forward, what we call iris bombé, the classic appearance of the acute angle closure glaucoma. So that iris comes forward, and now this forward pushing of the iris completely blocks Schlemm's canal. So any fluid that does happen to make it into the front of the eye can't get out of the eye anyway. So now you've blocked outflow completely, and pressure goes up very, very high because fluid is always being produced. So to treat that, we use a laser. Turn the laser on, we shine the laser into the back of the eye, and we zap the iris, and we drill a little hole with successive laser pulses through the iris. Then fluid can come out through that new artificial hole in the iris. The iris falls back into position, and aqueous outflow is restored, and that is how you treat and cure acute glaucoma. But in many cases, it's not an acute problem, it's a chronic problem where there's impedance of outflow here at Schlemm's canal and the trabecular meshwork. So how do we treat that? Well, we're starting to use these things called eye stents, these little micro valves, and we put an actual tube in there, right through Schlemm's canal, so fluid can get out of the eye easily. This is what an eye stent looks like. There it is in real life. You see it on the tip of your finger. Okay, so that's only $2,000 to $3,000 each. All right, so lots of money in ophthalmology, and we inject that into the human eye. There he is, just putting it in, and there's the end of the tube sticking into the eye to allow fluid to flow out. It's elegant, it's beautiful, and there's talk that we should do it to every patient. There's the echoing that comes when one of the sites doesn't have mute on. Okay, great. So the fluid is flowing out through the eye stent, and they're saying that we should do that in every cataract surgery now. Just part of cataract surgery, throw this in, you'll solve cataract and glaucoma at the same time. The problem is you take the cost of surgery from a few $100s, now you put a $2,000, $3,000 implant in, and suddenly surgery becomes very expensive, but you've solved two problems. So that's what's new in glaucoma. Okay, so we've done cataract, glaucoma. We'll move on to retinal vascular disease. So the retina, of course, is the film at the back of the eye, and that's what's involved in vascular disease. Here's a nice, beautiful, healthy retina. You can see the optic nerve here, which connects the eye to the brain, and the blood vessels which supply and nourish the retina. Where the arteries and veins cross over each other at the back of the eye is actually the weak spot. So in hypertension, arterial sclerosis, the buildup of cholesterol, all of those things that are occurring in elderly patients, the thick arteries start to compress compress the veins. So the veins get sort of compressed off because they don't have a thick muscular wall, and as the arteries thicken and harden, it compresses the veins, and then the veins start to dilate as blood is flowing into the veins, but they can't get through these blockages inside the eye. And the result is, boom, the vein ruptures and fills up the back of the eye with this blood and hemorrhage. We call it the blood and thunder appearance of a retinal vein occlusion. And they can be very nasty looking things, and they fill up the whole retina with blood. Now that the retina is filled with blood, of course it doesn't work well, and it can't interpret the images that are coming into the eye, and the patients lose vision. The risk factors for having a vein occlusion, a vascular event in the back of the eye, are age, hypertension, cardiovascular disease, BMI, glaucoma. So if the pressure in the eye is higher, you have a higher chance of having that, and diabetes. Now, the vision loss acutely results from the hemorrhage and the fluid and the lack of blood flow. That's the retina is suffering when the vein ruptures like that. But with time, we often form some collateral blood vessels that can shunt the blood around these blockages and allow the blood to leave the eye and decompress the retina. But in chronic cases, you're left with macular ischemia, or lack of blood flow to the center of the eye, chronic edema, pigmentary changes, the retina becomes dark and pigmented and doesn't work well, and you get scar tissue and membranes that form as a result of this injury. Traditionally, we used laser therapy to treat this. So we used a laser to zap the back of the eye. And basically what this was doing was trying to dry out the retina effectively in order to decompress the retina and restore normal anatomy. So here's some pictures of laser burns that I used to put in the back of the eye all the time. A major study of several thousand eyes that had that done indicated that laser therapy is effective. You had twice the likelihood of gaining vision if you had laser compared to if you just watched it. But our treatment wasn't great, so we needed better ways of treating the fluid and edema that was there in vein occlusions. Ultimately, the body can help us by growing collateral. So here's a patient who had a vein occlusion here and grew these new abnormal blood vessels. We always say they look like curly Q or pigtails at the back of the eye, and they circumvent an area of blockage. They can also form on the optic nerve, and we've got several little shunt vessels on this optic nerve as well that's helping to bypass the area in the retina that was blocked. So we call this vascular remodeling, and that's the ultimate way that the eye can heal itself. But in the meantime, what we're doing now is injecting things into the eye. So we love to inject things into the eye now to treat eye diseases. We love local therapy as opposed to systemic therapy for the eye. So one thing we're injecting is the Ozurdex implant. This is a biodegradable implant that lasts 6 months when we inject it in the eye. So it comes out under electron microscope, looks like this. It's filled with a steroid medicine, and as the structure that it contains degrades, the steroid is slowly released into the back of the eye to decompress the swelling of the retina and take away that edema and the swelling and allow the retina to work and allow the patient to see. So it's approved here in Canada to treat vision loss from retinal vein occlusion. It's supposed to last 6 months, although the effect really doesn't last as long as it says. But again, it's not cheap. These are well over a couple $1,000s each when you inject them into the human eye. There's the paper that shows best standard of care laser treatment versus how much better you can see. So this is improvement in visual acuity that occurs when you actually inject the steroid into the eye versus our alternative therapy. And this is how it's done. You just take the injector, stick it right through the sclera, the implant falls into the back of the eye and sits there for 6 months as it slowly digests and releases its medicine. And there's just us performing the procedure, sticking the injector into the eye. And there's one of my patients with the Ozurdex implant sitting there at the back of the retina. There's the optic nerve, and it's sitting way down here at the bottom. There's the patient pre-injection, post-injection. Visual improvement increases by almost a factor of 10, so the patients do very well. Sometimes strange things happen, like these implants can migrate and move up into the front of the eye. So here's that same patient 2 weeks later, and you can actually see the Ozurdex implant, the steroid implant, sitting there in the very front of the eye, just behind the cornea. And so people will be asking, hey, what's that funny looking piece of chalk that you have in the front of your eye? And they say, okay, that's just to treat my vein occlusion. And everybody says, okay, great. But there it was at the back of the eye. Now it's up there in the front of the eye. So these things happen. Of course, steroids in the eye do have negative effects. They increase pressure in the eye, they give glaucoma, things like that. But when people are going blind because of the retinal vascular occlusion, you can really help them out by injecting things into the eye, such as these long-acting steroid pellets. So that's what's new in retinal vascular disease. So we'll move on to my favorite topic, age-related macular degeneration. If I see 70 or 80 patients a day, probably half of them are for this particular reason, so patients coming in with vision loss. So macular degeneration is the most common form of visual loss in Canada today. If you stratify it by age, if you're young and blind, it's almost always diabetes. If you're old and blind, it's almost always macular degeneration. So those are the most common cause of vision loss in Canada today. Older people, it's macular degeneration. Younger patients, it's diabetes. But we're talking about the elderly, so macular degeneration is very important. Macula just refers to the anatomic center of the retina where all the light is most tightly focused. Okay, there's my little guy again. He's available for $10, this size. There's Jenna saying she loves retina, and Devin loves retina, but not quite as much as pancakes. All right, good stuff. So, macular degeneration, the leading cause of severe central vision loss in Canada today. You don't diagnose macular degeneration unless you're at least 55 years old. Really, almost everybody's over 65. It has a huge, tremendous impact on our society today, of course, because of our population aging. More and more people are going blind due to macular degeneration. The basic lesion is the drusen. So here's a nice healthy retina, beautiful pink healthy retina. Here's an older retina, and you can see these gray white spots at the back of the eye. Those are drusen, the accumulation of the byproducts of cellular metabolism that build up at the back of the eye. We call them drusen. I tell people it's like your hair turning gray. So as you age and you get a bit of gray hair, you get little gray spots in the back of your eye as well. We call those drusen, and those are the marker, the hallmark of macular degeneration. Under the electron microscope, they look like phospholipid vascules, and there's a picture of one there. So, it's a very common disease. 10% of our population over the age of 55 have macular degeneration. So 1 in 10 people have it. 9 out of 10 people, it's the dry form. So dry macular degeneration just means that you have drusen, you have pigmentary changes in your retina, and as those drusens aggregate together, they can actually sort of wash out or cause erosion of the overlying retina. So you lose vision, but in the dry form you lose vision very slowly as the drusen build up and accumulate. The wet form is the destructive, aggressive form of macular degeneration. It only affects 1 in 10 people that have macular degeneration, but they go blind very quickly and experience sudden visual loss. Wet just means blood and fluid. So now the drusen have accumulated to the extent that they've caused some damage to the layers of the retina that separate the underlying choroid, the rich vascular supply of the retina. These blood vessels are damaged, they bleed, and they leak. So they fill up the retina with blood, fluid, cholesterol, exudation, and vision goes down very quickly, very rapidly, and very profoundly. That's 1 in 10 patients, but that's the vast majority percent. So 90% of people who are actually blind from AMD have the wet, not the dry form of the disease. So our therapy is largely targeted towards treating wet macular degeneration. So vision loss, 10% of it is dry, so you get a coalescence of all the drusen together, and you get patches of atrophic change in the back of the eye. And this patient doesn't see well because their macula is basically atrophic, all the drusen have stuck together, and the overlying retina has degenerated. So they do lose vision. Some people that dry become blind, but it's less common. Most people who are blind, they're blind because of the wet form of macular degeneration. So there's the dry form, the phospholipid accumulations, the geographic atrophy. And there's the wet form. You get cholesterol, fluid, exudation, and blood. And then this is the end stage of macular degeneration, a large disciform scar. So the retina is now replaced by scar tissue as our body reacts to the chronic bleeding and fluid underneath the retina. It's good, it limits the vision loss. The scar now occupies the whole macula. This patient is unable to read, unable to recognize people, unable to see faces, unable to drive, of course. But they still have peripheral vision so that they can navigate and things like that. So treatment options, wet and dry, you've got to separate the two of them. So for dry macular degeneration, there's no cure, so we talk about lifestyle modification. Number one is to quit smoking. Quitting smoking trumps everything else. And 50% of my patients who have macular degeneration, they still smoke. They want to know what I can do to treat my macular degeneration. They want to know what pills I can take, what vitamins I can take, and the biggest thing they can do is just stop smoking. Okay, and that'll help the back of the eye. It'll cause less of these phospholipids, these byproducts of metabolism, these waste products to build up back there, and their macula will become healthier as soon as they stop smoking. Nutrition plays a very important role. Maintain a healthy body weight, so exercise and blood pressure control are important. And there's the whole debatable aspect of UV light exposure. But this whole concept of the role of nutrients in protecting people's eyes is a very important one, and it's spawned a whole industry, the nutraceutical industry for the eye. It's massive now. It's a huge industry. And it came from the fact that people who were eating healthier, people that had a better diet, certainly had less eye disease. So this led to a massive trial in the United States, the ARIDS trial, the age-related eye disease trial. It enrolled 10,000 people. It followed them over a decade. It was one of the most expensive trials ever performed. And it's basically performed actually to discredit the nutraceutical industry that were promoting all these vitamins to the eyes, and prove actually that, listen, you don't have to fill your medicine cabinet with all sorts of vitamin pills to save your eyes. We actually wanted to prove that you didn't need that. But actually it turned out that vitamins help, and vitamins help a lot. So it looked for the progression to wet AMD and the severe visual loss, and it proved that vitamins are actually very good for you, because it showed that after 5 years, your rate of visual loss decreases by 25%. So a fairly significant improvement just by taking vitamins to treat your dry macular degeneration. So the vitamins they used were vitamin C, vitamin E, zinc, copper, and beta-carotene. So those are the 5 things. The copper is there only to prevent the anemia that comes from zinc. And zinc actually, in the individual, if you look at them one component at a time, the zinc was actually the most beneficial thing. It's a catalyst that helps to mop up oxygen-free radicals in the retina. So it helps to eliminate the formation of these waste byproducts inside the retina. But nonetheless, taking vitamins is good for you, reduces your rate of visual loss due to dry AMD by 25%. Okay, what's new is ARIDS 2. ARIDS 2 is just publishing its first reports, and it looks at lower concentrations of zinc, because zinc gives you GI upset. Okay, you don't want to make people constantly nauseated by taking their eye vitamins. They also looked at adding lutein and zeaxanthine to replace the beta-carotene. So these are all carotenoids, or specific compounds that are well metabolized and build up within the retina. The risk of beta-carotene, the risk, of course, is lung cancer. So if you are a smoker and you take beta-carotene, you have increased risk of lung cancer. So they have formulations free of beta-carotene, and they looked at could they replace the beta-carotene with lutein and zeaxanthine, which are both macular carotenoids, and the answer is yes, and you can have an even better effect. And then they also thought that omega-3 fatty acids provide a lot of protection from oxidative stress and oxidative damage, and so their new formulations now incorporate omega-3 fatty acids in them to try to protect the retina some more. So why do vitamins help? What's the whole theory behind why vitamins help? Well, the back of the eye is a very metabolically active place in the body. There's a lot of metabolism going on, a breakdown of a lot of the cellular components which are leading to the buildup of these waste byproducts, specifically oxygen-free radicals. And it's the imbalance, too many oxygen-free radicals being produced and not enough of the antioxidants to mop them up and get rid of them, that leads to the damage in the retina from dry macular degeneration. So we try to put things in better balance by improving patients' nutrition and supplementing the patients with these vitamins. We can block the formation of oxygen-free radicals with lutein, zeaxanthine, and beta-carotene, which absorb the harmful blue light, which can build up in the back of the eye and lead to oxygen-free radical formation. And then you can actually give people vitamins like vitamin E and that can actually absorb them and mop them up, or you can give them things like zinc, which help to break down the oxygen-free radicals. So that's the whole theory behind the treatment of dry macular degeneration. So we look at vitamin C, vitamin E, the carotenoids, beta-carotene, lutein, and zinc, and then the enzymes that break down the byproducts of cellular metabolism more quickly. These are the carotenoids, the ones we talked about. They are the all the good stuff that comes from green leafy vegetables and the like, and the whole theory, listen to your grandmother, eat your green leafy vegetables, you'll see better. There's some truth to that because you build up more carotenoids in the back of your eye. So they actually work by filtering out high-intensity ultraviolet light that provide the protective effect. Now the question is, can they actually stop? So we know that they slow down the progression of dry macular degeneration, but can they actually stop the onset of macular degeneration? So there's a big article published several years now which actually looked at the onset of macular degeneration and looking at a healthy retina like this and seeing what your risk is to start any form of macular degeneration. And again, it took several thousand people and stratified them into 3 groups: those that had very sort of poor nutrition or low intake of beta carotene, vitamin C, vitamin E, and zinc, and those that had very high intake, and then the average intake in the middle. You can see that if you were in the high intake of the healthy vitamins and nutrients, if you had a better diet, you had a 35% reduction in onset of macular degeneration. So this study also fed into that whole industry that now promotes the use of vitamins for long-term eye health. And so you get several vitamins. I'll just show you some of the kinds here. Vitalux, for example, eye health, and they're promoting that to everybody now as a way of trying to reduce your onset of wet and dry macular degeneration by providing all the appropriate nutrients that the retina needs. Patients always ask me, they come in with their mom and dad who I'm treating for advanced macular degeneration. They always ask, what can I do? What can I do to prevent macular degeneration in myself? Because we know genetics plays a role, and most of them are paying money and taking these vitamins. But always remember that far more important than vitamin usage are those other risk factors. So if they just stopped smoking, had a better body weight, had better blood pressure, were more physically active, that actually has a more significant impact. But people feel better if they can take a pill to have the outcome that they want. So this industry has really taken off, and there's a lot of people on these vitamins, and there is scientific merit to their use to prevent the onset of macular degeneration. So that's dry macular degeneration. Wet macular degeneration is the most important area. This is the most important cause of visual loss in the elderly. Our traditional treatments were laser and photodynamic therapy, if you heard of that. We used to try to laser the areas that were bleeding, or photodynamic therapy was just to use a low-intensity laser after we injected the patient with a photosynthesizing dye that would concentrate in the area where it's bleeding, and then we'd zap that with a low-intensity laser to try to preserve the overlying retina, but fry the abnormal blood vessels that were bleeding to treat the wet macular degeneration. And these older therapies, all they did was reduce the rate of vision loss. So we tell people, you're still going to go blind, you're just going to go blind more slowly. So that was very unsatisfying as a physician to tell them. So in the modern era, we inject anti-VEGF medication, and we can confidently say to our patient, with this medicine, your vision is actually going to get better. So they come to me because they can't see well, and they want a treatment that will restore their vision, and now we have them. We have anti-VEGF medications. In the old days, we just used to tell people, okay, I'm going to treat you, and you're just going to go blind more slowly. Not what the patient wanted to hear. So now we have some good news to give them. We can treat them with anti-VEGF medication. So here's a patient bleeding, legally blind, 2400. We give them the injection, same eye after 3 injections, 2040, they're back on the road, they're back driving. So this has totally revolutionized our ability to treat wet macular degeneration. It's been an unparalleled success and made wet macular degeneration actually a treatable disease, and it's life-changing because people can now drive again, they can read again, they can have independence, and they have longer life expectancy by seeing better. So it's been a real revolution in our ability to treat eye disease. It doesn't work for everybody, but it's a very successful treatment. So what is this molecule, VEGF? Well, VEGF, or vascular endothelial growth factor, is the molecule that promotes the survival, proliferation, and migration of endothelial cells. So when the retina is damaged at the back of the eye, it starts to grow new abnormal blood vessels which grow up from the choroid underneath the retina, and these are the fragile blood vessels that leak and bleed in wet macular degeneration. It also promotes leakage. So if you have too much VEGF in your eye, the blood vessels that are there are leaking. They're leaking blood, fluid, exudation. So we turn off VEGF and we take away these blood vessels, and we can stop the leakage of fluid. That's how it works. So VEGF is a molecule with several different isoforms. All of them are in the back of the eye. VEGF 165 plays the most important role, but the other ones have different roles. as well. If you've got too much VEGF, so there's the VEGF receptor, VEGF comes along on the vascular endothelial cell, it binds to VEGF, and it creates the formation of new abnormal blood vessels. So you take an eye that looks like this. In diabetes, they start growing these large new blood vessels into the into the vitreous, and this patient's going blind in diabetes. In macular degeneration, they're forming these blood vessels underneath the retina that are bleeding and leaking. So what we can do is block VEGF. So the classic way of doing that is with the drug Lucentis. It's an antibody against VEGF. It binds to VEGF in the extracellular space. VEGF can no longer interact with its receptor, so the blood vessels are starved from VEGF and they undergo apoptosis, because it's an absolute requirement for a new blood vessel to survive is the presence of VEGF in their environment. So when you turn it off, the blood vessels regress and go away, and the bleeding and leaking stops. It doesn't affect mature healthy blood vessels, so the remaining healthy blood vessels in the retina are fine, but these new abnormal blood vessels that grow in wet macular degeneration are destroyed and turned off. If you give it systemically, blocking 50% of it in the body is lethal, so that's why we like to give it in the eye. There's many ways of targeting VEGF in the eye. We have Macugen, which is an aptamer that actually binds to VEGF. We have antibodies against VEGF. We have the VEGF trap. We have molecules that sit on the VEGF receptor in the cell so that VEGF can't interact with it. And we have some compounds like kinase inhibitors, small inhibitory RNAs, and squalamine that are inside the cell, work inside the cell to block the downstream signaling of the VEGF molecule. Aptamer was the first anti-VEGF agent approved. It works on all forms of wet macular degeneration. It binds here to VEGF 165, so that's where it binds right there. And when it was given, it worked well. But if you compare it to the other anti-VEGF compounds, they bind here in the conserved region of the molecule. So they actually block all of the isoforms of VEGF, what we call pan-VEGF blockade. That's much more effective. The Macugen, when we started using it, this is the rate of vision loss with best possible alternative to care, laser or photodynamic therapy. You can see that with Macugen, people were still losing vision just a little bit more slowly. So it was an advancement when it first came out, but by blocking just one type of VEGF and not providing pan-VEGF blockade, you don't actually improve vision. So that's why Macugen disappeared. Now we use Avastin and Lucentis. They block all isoforms of VEGF. They take a retina that's swollen and leaky and looks like this, and after an injection, they flatten the retina out, get rid of the fluid, and have a nice, healthy retinal appearance. Lucentis is the most common drug. It's a drug that's approved for use in Canada to treat wet macular degeneration. It takes the full-length antibody, which is actually Avastin, breaks it down into just the component that binds to VEGF, then matures it a little bit so it binds even more tightly to VEGF, and that's how you get Lucentis. Lucentis can permeate through the retina. That's what this picture is showing, the retinal layers, radio-labeled tracing of Lucentis. It permeates nice and through all the layers of the retina, gets down here to turn off those blood vessels, whereas the full-length antibody, such as Avastin, still penetrates, but much less readily. There it is going into the back of the eye. So they bind here at the conserved portion of the VEGF molecule, and all VEGF isoforms are blocked. And it's the first therapy that actually improved vision. So that's the phase 1 study, phase 2, phase 3. Massive improvement in vision once we give it to a patient. The problem is the drug wears off, so you have to give it every month for 24 months. If you want to follow the study protocol, and it's $1,675 per injection. In Ontario, it's $1,800 per injection in Quebec, and that doesn't include my fee for injecting and seeing the patient. So this is very expensive, but it works very, very well. So Avastin, the full-length antibody, which is very cheap. Actually, interestingly, a bottle of Avastin costs the same amount, $1,675, and they're made by the same company. It's just the bottle of Avastin has 1,000 doses in it when you break it up and give it inside the eye. So we have our pharmacist here at the hospital break it up into small doses. It costs only a few dollars a dose, but when you add in the cost of the pharmacist to break it up, it ends up costing the patient about $50 a dose instead of $1,675 a dose. And the major randomized clinical trials, the CAT trial, the IVAN trial, major trials that come out have shown the effectiveness to be the same. The concern is with Avastin being the full-length antibody that's approved for use against colorectal cancer and stuff, is that there may be more systemic side effects. The first trial that used Avastin actually gave it systemically, and 2 of 15 patients died. Okay, Okay, so people die from Avastin. That's okay if you're dying from one of these forms of cancer and you want to slow down the cancer, but when you're treating an eye disease, we don't want to hear about that. So that's why you give very small doses of it directly into the eye, and it works very effectively. So there's Avastin, much cheaper than Lucentis. The disadvantage is we don't have any long-term study. It's never been studied because the same drug company makes both of them, right? So there's no impetus to study the cheaper version of the drug. So we don't really know a lot about its long-term effects. But there's been 60 million doses given of it on a worldwide basis as of a couple of years ago, so it's widely used. Some of these other ways of stopping VEGF, squalamine. Squalamine was given systemically as well. It was given by intravenous injection. I gave it to several patients, but again, people don't like to be hooked up to an IV to have their eye treated, so it's sort of fallen out of favor. I'll just skip through that one. The same with small inhibitory RNA. The VEGF trap, though, is a very popular one. It's a new one. It binds the VEGF molecule in the extracellular space. The advantage of the VEGF trap, it lasts longer. So it doesn't disappear in 1 month, it disappears in 2 months. So you can cut your rate of injection in half by using it. So that's the VEGF trap. Some of these other ones, the small inhibitory RNA, it's great. It goes inside the eye and actually mops up all the messenger RNA that would have gone on to produce VEGF. So it turns off VEGF formation inside the eye, but it's still in experimental roles. And a lot of the money that was being used to develop that has sort of disappeared as these other therapies are now approved. So that leaves us really with just these 3 compounds that we're using to treat VEGF: Avastin, Lucentis, to treat wet AMD. Avastin, Lucentis, and the VEGF trap, or Eylea. And they're all different, slightly. Avastin, never designed, never approved to be used in the eye, but widely used because it's so cheap. This concern is the possible systemic effects, but it gives the patients the ability to have a beautiful, new, modern medicine to treat their wet macular degeneration at a very affordable rate. Lucentis, the one that's designed, approved, and studied to be used in the eye, but it's very expensive. It only lasts a month. And Eylea is the new kid on the block, just recently approved. It only has to be injected half as often, so they doubled the price of it. Okay, so the savings to OHIP is they don't have to come in to see me as often, right? So there is still some savings, and it's a big savings for the family, right? Because when you think about how often you have to inject these compounds into the eye, it's a huge factor when you're doing it time and time again for the society, for the patient, for their family, and for me, because now I have massively overbooked clinics just sticking needles in patients' eyes. But it's working, so we do it. The future, the long-acting implants, that's the future. So here's another long-acting implant. Take a look at this little guy. It's only a couple of millimeters in size. We drop it in the eye. I've put in 6 of them recently. Or you can have the version that screws into the eye like a little screw, and you screw it through the steroid into the side of the eye, and it's got the medicine here as a slow-release molecule. $40,000. But lasts for 2 years. So if you go $1,650, multiply it by 24 doses, you're cost neutral, but you only have to have 1 procedure. Okay, the ultimate, of course, will be topical therapy. All right, so to summarize then, the major causes of vision loss in the human eye, in the aging human eye: cataract, for which there's excellent surgical treatments, and the new therapies are all these new high-definition lenses, okay? We have retinal vascular disease, risk factors is age, diabetes, hypertension, and now we have long-acting steroid implants we can inject in the eye. Glaucoma, high pressure in the eye, for which we have medical and surgical treatment, and now we have these microvalves which we can inject into the eye. And of course, macular degeneration, the most common cause of visual loss. We have new exciting treatments which is really making this a very treatable disease, but what we need is long-acting formulations so patients don't have to come every month to have their needle in the eye. And that's my little guy saying thanks for listening to my dad, and my little girl, and my third one saying thanks. All right. Thanks very much for your attention as we did the whirlwind tour of eye disease.